I think the last set of questions actually highlights something that's really important that you can look at two ways. This is all very hard. This isn't easy. It isn't easy for our patients. It isn't easy for our families. And there aren't easy answers on the science side. It takes a village. It takes a village working really hard. But I think as the work progresses, we'll start to answer some of these questions. Sandy's probably better suited to answer this, but it seems, even to my eyes, every couple years, we'd like it to be every couple months, but every couple years we've been chipping away at another piece of these issues. And with steady commitment and work to this, I think we'll continue to chip away. So you heard about from Brian the genetics issues related to autoimmunity. My role is to take the next side in terms of the epidemiology of autoimmunity. And we can go ahead and put up the slides. And the idea here is ultimately to answer the question, why did Fred get this disease? And you can fill in any disease you want, but not Harry. So Fred has a disease, Harry doesn't. You've all experienced this. You got diagnosed with neuromyelitis optica, but your sister's perfectly healthy. You got diagnosed with transverse myelitis, but your spouse has been perfectly fine. What was it that either was in Fred's genome, or what did Fred do as a child? What did Fred not do as a child? What was it that led to this condition? And in the end, as Brian summarized quite nicely, this is labeled for multiple sclerosis, but it's true for all of these diseases that you have a genetic predisposition. There's something about you that puts you at risk, but being at risk is not enough. You have to have the right exposures in order to go on to have a disease. This concept seems rather intuitive to us in 2010, but it hasn't always been the case. When you go back through history about diseases, if you came in with the symptoms of optic neuritis or transverse myelitis 500 years ago, we'd say you have an imbalance of bodily humors. You have too much black bile. You need to get rid of your black bile. And we all chuckle, and 100 years later they chuckled at this. You came in with the same optic neuritis, and somebody said it's humors, and they said, oh, it's not humors. We disproved that 100 years ago. You have a small dwarf living in your stomach that's causing problems, and if you get rid of the dwarf, everything will be better. And this is something that's constantly in evolution as we learn more and get smarter and study more in rigorous fashion these different diseases. So if you look at the most common neuroimmunologic disease, multiple sclerosis, it's kind of fun to go through history and look at what were the reported causes of MS. So if you were diagnosed with multiple sclerosis in 1900 and you went to your doctor and said, Dr. Greenberg, why did I get this? I'd say, you're not sweating enough. Go to bed, pull the covers up over your head, sweat, 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 and this will get better. Probably not the best advice. In the 19-teens, Dr. Greenberg, why did I get this? You've been exposed to some toxic agent. We need to purge your system of the toxin. By the 1940s, it was all about circulation. We need to get the blood flowing through your arteries and veins better and give you some vasodilators and you'll be better. By the 1960s, we started talking about allergic reactions relative to MS. Why is this? Well, it was during these 20 years that there were explosions in the world of immunology. And so we started talking about autoimmunity. And in 2000, if you had asked what caused multiple sclerosis, I'd tell you it's an autoimmune reaction against myelin, and the immune system goes in and causes damage. This isn't completely correct. It doesn't explain everything in multiple sclerosis. An autoimmune reaction to the spinal cord doesn't explain everything in transverse myelitis or neuromyelitis optica. It's an incomplete explanation, and what we have to do is sort out what are the missing pieces. So what do we know epidemiologically about these conditions? Well, one of the questions I get asked after a diagnosis is, how common is this? And I say it's pretty rare. People go home, and then I get a phone call or an email about a week later, and it's something along the lines of, Dr. Greenberg, you need to call the CDC now. I've talked to my neighbors, I've talked to my cousins, everybody's got an autoimmune disease. What are we being exposed to? What's going on? And if you look at the incidence of autoimmune diseases in our community, it is indeed rising. So again, if we take the example of multiple sclerosis, from 1985 to 2007, there has been a steady rise in the incidence of MS. And people say, well, are we just diagnosing it more? And if you do relatively well-controlled studies, there is a component of that, but it by no means explains the increased rate that's going up. This is an interesting fact that is a little scary, but it also says, well, if we know this, we should be able to point out what is going on during these 20 years to lead to the increased incidence. So let me make it more complicated. For some of us in the room, the incidence of autoimmune disease is going up much more than others, and who knows the answer to that? I'm sorry for our women in the room, but this is being driven purely by women. The incidence within men is staying relatively static over these 20 years. The incidence in autoimmune disease is really only going up in women, and this is not just true for multiple sclerosis, but a variety of different autoimmune diseases. Now, this is where it gets fun. You know, this is fodder for lots of different theories, a few really bad jokes, but it's also the focus and gives you a hint as to maybe one way to start answering the question. Because if you can explain why the incidence for autoimmunity is going up in women for the last 20 years, what you're really asking is causation. And once you identify causation, you can start to talk about total prevention and ultimately cure. So these are different avenues to try and sort it out, which is going to be the point of the rest of the talk. How do we prove causation? There have been lots of theories over the years for autoimmunity, neuromyelitis optica, transverse myelitis, multiple sclerosis. I'm going to give you a few vignettes, a few stories relative to causation, and we'll start with causation in multiple sclerosis. And for years, we talked about the idea of multiple sclerosis being an infectious disease. Is there any evidence to suggest that multiple sclerosis is actually caused by an infection? So there are lots of lines of evidence. So one is related to this small dot of islands here north of the UK, in between Norway and Iceland, called the Faroe Islands. And the Faroe Islands, it turns out, has had an excellent medical system for over 100 years. This was the first HMO. They had a single national physician who had to review all the records of everybody on the islands on a regular basis. Again, multiple jokes can be made about this, but it makes for a great epidemiology study. And when you go back and you look at the records of the Faroe Islands and you look through the 19-teens, 20s, and 30s, there is not a single case of a person who's indigenous to the population that looks like multiple sclerosis. Nobody presenting with any symptoms or signs that look like MS. And when you get into the 1940s, right around 1943, 44, and 45, there is a huge, using the term outbreak, of multiple sclerosis for the first time ever, and then it trails off over time. So this is a great study when you look for outbreaks to look for the question of an infectious agent. So what happened in the Faroe Islands in the late 1930s, early 1940s? What did they get exposure to? What they got exposure to were the British. So in World War II, the Brits, for the first time, housed their troops, billeted their troops in the Faroe Islands, and did it within communities. So the troops were living with families, and within a couple years of this massive migration of a population from the UK into the Faroe Islands, there was what looked like an outbreak of multiple sclerosis, and after the British left, the number of cases died off dramatically. And so what the Brits brought with them, I am not quite sure. When you look in other studies for infectious causes of multiple sclerosis, there have been numerous viruses that have been looked at over the year. If you look at the literature 40 years ago, it was canine distemper virus. And then a few $1 million of research and lots of study, it turns out it's not canine distemper virus. And then they said it's measles. Another few $1 million of study, it turns out it's not measles. And then a paper comes out that says we've tested the blood of patients with multiple sclerosis, and 98% of them have positive antibodies to Epstein-Barr virus. Epstein-Barr virus causes multiple sclerosis. 98%, that's a pretty big number. And then a few months later, they did the study looking at healthy controls, and 95% of healthy controls have been exposed to Epstein-Barr virus. So the 98% isn't as impressive anymore until you look at the data another way. And a group of very smart epidemiologists at a small institution in the Boston area that shall remain nameless looked at the odds of getting multiple sclerosis if you had no exposure to Epstein-Barr. So OR stands for odds ratio. How likely is it? And basically it turns out to almost never happen. It is extremely rare to find an individual in the world with multiple sclerosis who has not been exposed to Epstein-Barr. So this was intriguing, and groups have looked at this in a variety of ways. One way was to look at a very unique, rare group of MS patients, and that's pediatric MS patients. And it turns out if you take a group of 8-year-olds who have multiple sclerosis and you compare it to a group of 8-year-olds who do not have multiple sclerosis, the rate of Epstein-Barr exposure is twice that. So the multiple sclerosis group is double the healthy controls, and that is not true for other viruses. And so the risk seems to really make a difference, and as the exposure makes a difference in the risk. And as Brian already mentioned, when you combined exposure to Epstein-Barr with a certain genome, your risk skyrockets. So if you have a certain genetic background and you get exposed in a significant way to Epstein-Barr, your risk is tenfold an individual who is negative for the gene and has no or low exposure to Epstein-Barr. So this is an example of the right host, the right exposure, increasing your risk. But this doesn't explain everything. And it brings me to the next story within multiple sclerosis. Within MS, we've known for years that it matters where you live. The further away from the equator you get, whether you're going north or to our colleagues and friends south, towards Australia on the other side, the further away from the equator you get, the higher your risk of multiple sclerosis. So if you live in Minnesota, your risk is significantly higher than living in Dallas, Texas. And that risk gets set somewhere by the age of 13 to 15 years of age. So if you're born in Texas and you make the life-altering mistake to move to Minnesota before the age of 13, you acquire the risk of somebody in Minnesota. Whereas if you develop and live out your life in the great state of Texas and you move after 15, you keep the risk of a Texan. Does that make sense? So it's something within development, early teenage years, that makes a difference in terms of the risk. And people have looked at this in a variety of ways. They've documented it in different studies. You can take the Mason-Dixon line within the United States, and if you're north, you have a higher risk. If you're south, you have a lower risk. People in the south still get a lot of multiple sclerosis, but the answer was why. There are lots of theories to explain this. One interesting one is to take a NASA-developed map of the world based on UV radiation exposure and overlay it a map of multiple sclerosis incidence. And the less UV exposure you get, the less sunlight you get, the higher the risk of multiple sclerosis. So the further away from the equator you got, the higher your risk. And one of the reasons to explain this would be the issue of vitamin D. So it turns out that study after study have shown in multiple sclerosis that vitamin D deficiency is indeed a risk factor for developing MS. The first study to show this was the Nurses' Health Study. Is everyone here familiar with the Nurses' Health Study? This is a remarkable piece of research. This has been going on now for over 3 decades. The numbers between 30 and 50,000 nurses who were recruited shortly after graduating school over a series of many years, and every year they fill out surveys. Many of them give blood samples, they give their medical records, and over 30 years, and more than 30 years, the continuation rate has been astounding. Over 85–90% of the nurses for these 30 years have stayed in the study. If you enrolled 10 physicians, you'd have a 50% dropout rate after 2 years. The nurses have stayed in for 30 years, and the data has been extraordinary. It's looked at risk factors for cancer, looked at risk factors for hypertension, stroke, and indeed multiple sclerosis. And it turned out that individuals who on a survey responded that they had a diet high in vitamin D or they were taking supplements, they had a statistically significant reduced risk of developing multiple sclerosis. That's a great piece of information to have, but it's based on surveys. That's not hardcore science. What would be the best study to prove that if you have low levels of vitamin D, your risk of MS goes up? Well, the ideal study would be to have blood samples drawn on people on a regular basis, follow them for years, and then figure out, did a vitamin D deficiency increase your risk of multiple sclerosis? And it turned out that that study was possible. So in 1984, at the height of the HIV/AIDS epidemic really brewing in the United States, the military passed a rule. The Department of Defense said every active serviceman and servicewoman has to have a mandatory HIV screen once or twice a year. And the idea was, if you're HIV positive, you're not in an active combat role for fear of blood exposure. And so that was the reason. Somebody was brilliant, and they banked every sample since 1984 in a warehouse in Silver Spring, Maryland. And to date, there are over 40 million blood samples from over 1 million individuals with medical records through the VA system kept. And we know what's happened to these individuals. Out of those 1.2, 1.4 million individuals, 3,300 developed multiple sclerosis, several developed neuromyelitis optica, several developed transverse myelitis, and we have blood put away for years prior to their diagnosis. So when you go and you interrogate that resource, it turns out that if you were vitamin D deficient for a period of time beforehand, your risk of developing and being diagnosed with multiple sclerosis was significantly higher than people who were vitamin D sufficient. So we got a glimpse in real time that it makes a difference. But there are a lot of things that can change your risk of all of these diseases. So who here was born in May? Anyone born in May? Our May birthdays here, Geminis. So you have a statistically significant increased risk of multiple sclerosis. So anyone here born in November? Any Novembers? I have really bad news. For November, it's a certain kind of brain tumor. Anyone born in September? September, it's going to be subarachnoid hemorrhage, bleeding in the head for September. So it turns out you're not safe. No matter what month you're born, there's a study to say you have an increased risk of something. And my favorite, any December birthdays? December birthdays, you have a higher risk of living past 105 than everybody else. Merry Christmas. And so I don't know if that's a good thing or a bad thing. What's fascinating about all these studies, so instantaneously you open the article, you just heard about vitamin D, you open the page that talks about increased risk of multiple sclerosis in May, and you say, geez, well, mom was pregnant with me through winter, and winter vitamin D levels drop. It must be that in utero, vitamin D insufficiency increases your risk of multiple sclerosis. And indeed, there are papers out there that discuss this. But then, of course, there are papers that say in utero, excess vitamin D leads to a brain tumor. So, you know, it cuts both ways. You have to be careful with your theories. And the question is, how are we ever going to sort this out? And there are a number of efforts underway to sort this out. There are a few NIH-funded studies, but not as many as we would like. The Multiple Sclerosis Foundation has funded studies not just for MS, but relative to other demyelinating diseases. A group of you, some who are walking around with Band-Aids on your arms, are wearing the mark of the Accelerated Cure Project in collaboration with the Transverse Myelitis Association and the Guthrie-Jackson Charitable Foundation on NMO. And the Accelerated Cure Project is our best effort at trying to sort out these genetic environmental interactions for these diseases. And let me tell you why. So let's go through an example patient. And you'll have to tell me how many of you here have experienced that this applies to you. I think it's going to be everybody. So who here was born? So at some point you were born. At some point you had exposures, little Timmy in the 3rd grade, bubblegum in the hair, whatever it was. At some point you had illnesses. You developed croup, chickenpox, high blood pressure at some point. And then you had a symptom. And in our world of neuroimmunology, transverse myelitis, optic neuritis, you had vision loss, numbness, tingling, weakness, pain, some first symptom. And at some point you were diagnosed. Possibly incorrectly, possibly correctly, but at some point you got a title for your illness that explained your symptom. Hopefully you were treated, and hopefully you had an outcome that was good, and hopefully improving all the time. The ideal study to figure out what caused this event would track people from cradle to grave. We would be tracking data and samples from the time somebody was born to the time they died so that we could sort out the why. Is this possible? Is it feasible? In the world we live in, can we do it? The answer is probably not, although the NIH has started the Children's Health Initiative, where they are recruiting 100,000 newborns who will be followed from 0 to age 18 with regular evaluations and blood draws. It is an immensely important project. The only criticism I have of it is they're stopping at 18. You should follow this cohort for as long as you can and learn as much as you can. What we do is we focus here. A patient gets diagnosed, they're treated and has an outcome, and what we need to do is take the opportunity to learn as much about the patient in retrospect and figure out what exposures they had. And so this brings up the idea of the biorepository. So remember the military warehouse? When you walk in, there's these what look like FEMA trailers, and they're all lined up through the warehouse, and each of the FEMA trailers has hundreds of thousands of serum samples in it. And you walk in, and you can find the ones you want, and then use it for research. They started back here collecting blood. For the work we do with the Accelerated Cure Project and our collaborators, we're starting here, which isn't bad. In fact, it's quite helpful for answering a lot of the questions about why did this happen. We can make associations based on vitamin D levels. We can make associations based on infectious exposures. We can make genetic determinations. But we have to understand that we're in the dark a little bit. We're starting late. And so this is why I take what I call the Donald Rumsfeld approach to biorepositories. Everyone remember Don Rumsfeld? So this is our former Secretary of Defense under George Bush. He was one of the best guys to watch giving an interview because he didn't take crap from anybody in the press corps. He would give it back. And at one point, he was asked a question about the Iraq War, and he gave an answer, and while listening to it, I realized he had summed up all biorepository research perfectly in a sentence. And this is what he said. Reports that say that something hasn't happened are always interesting to me because, as we know, there are the known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are things that we don't know. But then there are the unknown unknowns, the ones we don't know that we don't know. This is biorepository work in a nutshell, and he nailed it. And what it underscores is the fact that as we approach research, we tend to be arrogant. And I don't mean this in a negative way, I mean it in a very human nature point of view. If I'm a geneticist approaching research, I assume it's a genetic condition. So I acquire samples and I ask questions from a genetics point of view. If I'm an infectious disease physician, and I have a father and a brother who are infectious disease physicians, so I can tell you a lot about them. If I study, they're convinced everything's infectious. I come home and they say, you're still studying this? Come on, just find the virus, Greenberg, find the virus. Everything's an infection. But we don't know what it is, and we don't know what questions are going to be asked tomorrow. If you look at the last 10 years, the number of scientific and medical breakthroughs that 10 years, which is not a long time, that has completely changed the way we do research and completely challenged the way we ask these questions, we could list off a dozen of them right now without batting an eye. For the scientists in the room who deal with genetics, the idea of microRNA and small inhibitory RNAs had never been heard of 10 years ago. And if you look in the literature now, there are literally over 1,000 articles in the last 3 years written on microRNA. It has changed the way we understand disease in humanity, and we had no idea it existed 10 years ago. If we were doing a biorepository 10 years ago and had assumed we didn't need to collect RNA, we would have shot ourselves in the foot. So you have to go with an open mind. Here's the current example of research today. Scientist number one recruits their patients, so I'm at UT. You're one of my patients. I say, please roll up your sleeve, give me some blood. I go back and I look for whatever I'm interested in, your vitamin D status. And Brian's group at the Mayo Clinic gets recruited to do a genetic study. And the group from Ohio State University recruits their patients to get Epstein-Barr status. And we each publish our little paper, 100 patients here, 100 patients there. And we say, see, there's a moderate effect of genetics, a moderate effect of vitamin D, a moderate effect of Epstein-Barr virus status. This is where we should be, and that is we all access all of the patients. Why 100 in each group when you could do 300 across all the studies? And we determine the vitamin D status, genetic status, Epstein-Barr virus status on all 300 patients, and then correlate the data. If we know that this isn't purely a genetic disease, you shouldn't just study it from a genetic point of view. This model is the Accelerated Cure Project. So in collaboration with the TMA and Guthrie Jackson, what they're doing is turning what could be a worthless sample into liquid gold. They keep track of exactly how the sample's acquired and how it's processed. They keep track of the clinical data about the patient. And most importantly, they create a biorepository that is open access with multiple specimen types. If you want to look at genetics, look at genetics. If you want to look at cells, look at cells. If you want to look at RNA, look at RNA. It is all available from all of the patients, free of charge to researchers, on one rule. The researchers have to give their data back to the central repository, such that when I go to look for an Epstein-Barr virus exposure, I already know their vitamin D status. I don't have to reinvent the wheel. And through that single rule of sharing back data, they foster collaboration and create a lot of great work. And Holly's going to talk about this some. But this effort, from the epidemiology standpoint, is really our best effort at trying to find out what causes this. And really that effort is summarized here, and that is the idea that we are going to have better answers tomorrow, and those better answers on why this happened are going to lead to better treatments and better preventions. I went home the other evening after a particularly long day at work, and I have two daughters. These are my two girls. going to bed, and this is actually the greatest study in genetics and environment. So this is a clone of mom in every way. This is unfortunately, she got the Greenberg genes pretty hard. And I asked my mom, I said, was I this stubborn? And she just laughed, yes, you were that stubborn, because she's incredibly stubborn. But I get home, and they're just getting into bed, and I was running incredibly late. Finally got there, and I sat down with Hannah, my youngest, and she says, Daddy, where were you? I said I was at work, what we were doing. Well, I was seeing one of my patients. We were seeing someone at Children's. She said, well, what's wrong with them? And they know, I don't know if Paula's in the room, but my girls are very close with Paula Zeri, and they know about what Paula's been through. And she said, what's wrong? And I said, well, she has what Miss Paula has. And she says, you haven't fixed that yet? They get you coming and going, it's just zing to the middle. And what I told her, and what I'll tell you, is we haven't fixed it yet. We are working on it at, to us, what seems like a feverish pace, and from the outside is like watching grass grow, is as slow can be, and it is a hard thing to go through, but it is a partnership between us, the organizations, our patients and families, because these kind of efforts cannot happen without your buy-in and your support, and we're very appreciative of it. So with that in mind, I'm not going to take any questions now. You can grab me. We're going to transition and give everybody a 5-minute break. We're doing okay, but not perfectly on time. And so if we'll take a 5-minute break, come back, and we will transition to talking about those grassroots efforts that are going to make a difference. I appreciate your attention.